Hello and welcome to Bladder Cancer and COVID-19, a regional update for patients and their families. This is Stephanie Chisholm and I'm the Director of Education and Research with the Bladder Cancer Advocacy Network. I'd like to just point out a few things at first. Attendees are in listen-only mode. If you have questions for any of our presenters, please use the question and answer tab at the bottom of your screen to submit the questions as you think of them. Remember that we cannot give specific medical advice, but we'll answer as many of your general questions as we can at the end of the program. And we will be able to share this information with our other experts as we do different programs around the country as well. So thank you so much for joining us. I would like to take a few moments and give you a quick view of my screen. I'd like to welcome our speakers today, urologist Dr. Gary Steinberg, who is the chair of Beacon's Scientific Advisory Board, and he's at the NYU Langone Cancer Center in New York City. I'd like to welcome you, Gary. And Dr. Kent Mao is here. He is a radiation oncologist at Dana-Farber Hospital in Boston, Massachusetts. Dr. Arjun Bladder is a medical oncologist, and he is there with Gary at NYU in New York City. And Dr. Keeler is representing our community-based physicians. He's a urologist, and he is based out of Voorhees, New Jersey. So thank you all so much for coming and joining us today and helping us figure out how to do this program and be able to share what's going on in everybody's communities. What I'd like to do right now is ask you to just kind of weigh in a little bit on what is going on in patient care in your areas. You have major hospitals, and then you also are dealing with a physician's office. So Dr. Steinberg, if you want to kick it off and just let us know from a urologic perspective, what's happening? You're in the center of things with Dr. Bladder in the New York City area. What are you seeing in your practice?
Well, first of all, I want to commend all of our hospital workers, and I must say our hospital administration and leadership throughout the country, because there's no question that the whole medical community has taken this extremely seriously. And I think that the whole medical community has mobilized very, very quickly, much more quickly than I could have imagined in my lifetime. I wish we would have had a little bit more lead time to have gotten even more prepared. But I think that all of the rules or guidelines that have been set out, the hospitals have been, and the healthcare workers have been leading the way in terms of social distancing. We jumped on telemedicine very, very quickly. We're trying to think very hard about eliminating unnecessary visits, having patients be able to get tests and imaging and so forth with really as safe as we possibly can. Having said that, this is a really once-in-a-lifetime, life-threatening problem that we have to continue to evolve and improve our ways to keep people from becoming infected. As we know, our bladder cancer community, our bladder cancer patients tend to be older. They have other medical problems. They can be in urban settings, rural settings, metropolitan areas, so it's a broad array of America, and we really have to work in partnership with our patients so that we can keep them safe. But the healthcare system has really responded tremendously well, and we're doing great things, I think, and doing the best we can. You're on, Stephanie, you're on mute. You're on mute, Stephanie.
As a medical oncologist, Arjun, what are you seeing in your practice in terms of every day? There are a lot of different major cancer organizations that are trying to address some of the needs of cancer patients. What are you seeing for your bladder cancer patients? Because that's a really subpopulation that's very specific in their needs.
Yeah, so to echo what Gary is saying is that we are very much in New York City an all hands on deck approach to taking care of patients, and this includes obviously patients with COVID, which is the primary concern that our hospitals just literally full to the brim with patients with infection. And what that's forced us to do is to come up with kind of novel and creative ways to help still take care of our patients with bladder cancer, whether it's localized or advanced disease, and shepherd them through the process as safely as possible, to treat disease as safely as possible, adhere to standards of care as best we can, and also so that we don't compromise outcomes, but also at the same time protect them from the toxicities of therapy so that we don't expose them to undue risk in terms of COVID. And also one of the biggest challenges, that Dr. Steinberg may have mentioned is that, our ability to bring patients into the hospital to perform necessary surgeries has also been challenged. And so that's forced us to come up again with creative ways to treat patients, to safely treat their cancer while they can, safely delay surgery. And so that's what we have done. We've prioritized patients in terms of where they are in the course of their treatment in terms of metastatic disease early in the course versus later in the course. And we've developed algorithms for that. And also for patients with localized disease, we're finding ways to treat them systemically earlier on and safely with chemotherapy also as well in certain scenarios to help us delay surgery. But it's been an unprecedented challenge. But we benefit from having so many people who are such experts in the care of bladder cancer that we're doing the best we can. Stephanie, you're mute again.
Yep, got it. Just takes me a second. So
Yeah.
Thank you so much. I think we'll talk more about some of the specifics as we go through this program. Dr. Mao, you're up there in Boston at Dana-Farber. What's happening up there? You're a radiation oncologist. Are you seeing change?
Yeah, no, thanks, Stephanie. Thanks for having me. I think this is a really important topic, and so I'm happy to be part of this. I would say that, at least to this point, we haven't been affected to the same extent as our colleagues in New York. That said, the hospitals are full here, and we're all operating, clearly under different circumstances than we're used to. Our beds in our ICUs are full of COVID patients. As a radiation oncology department, we've also made some significant changes in the way we do business. We've, as many folks have already noted, moved largely to telemedicine visits for all patients who don't need to be in the department. But for people who are coming daily for radiation treatments, we've continued to stay open. We've continued to treat patients. I would say our overall volume is down a little bit, and that allows us to space patients out a little bit more. We've been, really trying to minimize foot traffic in the department, so we ask patients to come in alone whenever possible. Everyone's wearing a mask at all times, and we've really tried to minimize, the time in department for the patients. I'm still treating many bladder cancer patients who are either, getting their course in the middle of their course of radiation when the COVID hit, or who, had disease such that we didn't believe we could wait to start radiation. And so we are treating those patients. We're treating them safely. Whenever possible, we're using abbreviated, shortened radiation courses, so fewer visits to the department in total. But again, as Dr. Bladder stressed, we want to do things, guided by data. And so, all of the, despite some of the regimens being somewhat shorter than we typically do, these are all things that are supported by data. We believe that they're just as good, that they can be safe, and that patients will still have similar outcomes, while obviously trying to maximize everyone's safety and minimize exposure to COVID.
Excellent. Thank you so much for joining us. We really appreciate that perspective. Dr. Keeler, if you could just give us a quick input as far as you are a community-based practitioner, yet you do surgeries in your local hospital. What are you seeing? Oh, you just signed off. He'll be right back on. We'll get back to Dr. Keeler in just a few minutes, I guess, as soon as he gets back on. I apologize for that. Go ahead and move on to the next slide, and just looking at this perspective of, when is it okay to have delays in treatment, and what should patients know? Because I hear all the time, I'm getting emails constantly from the doctors that are telling their patients, no, you can't come in right now. We're not seeing patients for surveillance. We're not seeing patients for treatments. You're going to have to push it off for a few weeks. When is it okay to delay treatment or surveillance? Because patients have a hard time kind of sitting quietly with that.
Yeah, I think that it really does depend on the stage and the grade of the bladder cancer. And so I'm going to talk a little bit about the non-muscle invasive bladder cancer patient population. We do have a fair amount of data that can place patients in the low risk, the intermediate risk, and the high risk populations. But we have to remember that with non-muscle invasive bladder cancer, while there certainly is a significant risk for bladder cancer recurrence, the risk for progression is, at least within 12 months, is relatively low. Even in our high-risk non-muscle invasive bladder cancer patients, the risk for progression to muscle invasion within 12 months is really about 17%. Clearly, when we look at 5 years, it's up to 45% risk of progression to more invasive disease and potentially muscle invasion. So we do have a good 12 to 24-month window, I believe, to really determine which direction a patient with high-risk non-muscle invasive bladder cancer is going to, which way they're going to go. And so I think that a delay with non-muscle invasive bladder cancer, even the high-grade disease, of 2 months, 3 months, is while it certainly is upsetting, it certainly is something that the patients are very unhappy and ill at ease with. I think that overall the risk for their cancer is not nearly as great as if they've got muscle invasive disease or metastatic bladder cancer. I think that we truly have to weigh the risk of having patients come in for TURBT, especially in, for example, New York City, at the time when their greatest risk of mortality is coming down with a COVID infection rather than their TURBT. Even though all urologists think we're great surgeons, patients have complications. If they need to come back to the ER or get readmitted or they have bleeding post-TURBT, our ability to take care of them is really quite limited and made much more complicated. In terms of trying to get intravesical therapy, again, I think that patients, our doctors' offices are using social distancing, where the rooms are being cleaner than I've ever seen any hospital or any clinic. And I think that it is safe for a patient to come in, get some intravesical therapy, and go home. One of the things I want to clear up is that BCG is an immune system stimulant. It's not an inhibitor. It's not going to make somebody immunocompromised. If anything, it will stimulate a patient's immune system, and that hopefully it has some off-target stimulation that may be protective against infectious disease in general. Is it a protective against COVID-19? Nobody knows, and that I think would be a pretty large leap to say that it can be or should be. Certainly it needs more study.
Thank you. Dr. Bladder, what are you seeing as far as when can patients delay treatment? When should they think about coming in for their treatment? What's important in terms of chemotherapy or immune therapies?
Yeah. So, I'll kind of break down the answer to that question into two kind of disease categories. Those patients who have metastatic disease and then those who have localized. So in the case of metastatic disease, we have tried to prioritize patients in terms of, does it really medically necessary to come in, really for patients who are early in the course of their treatment. So these are patients who are newly diagnosed or recently diagnosed. They are certainly within the first 3 months of their treatment. And, for us in the medical oncology world, this is the time period where we have our best opportunity to get disease control and also to really shape the prognosis of the patient. And so coming in for treatment is really critical in the first 3 to 4 months. And, with chemotherapy, we generally give up to 6 cycles of treatment up front with platinum-based combination, and each cycle is 3 weeks long. So you're roughly looking at 6 times 3, 18 weeks of therapy. And so that's really the meat of the treatment right there, right? So that's the first 3 to 4 months. And so we try our best to keep our patients who are on systemic chemotherapy, they're on. The places where we have the opportunity to reduce the number of visits is in particular in patients who've received immunotherapy-based treatments. And we know that treatment can be given indefinitely, safely at least. The data supports as little as a year, possibly 2 to 3 years or longer. based on the current evidence from phase 2 and 3 trials. But I know, from our experience and with those of others, is that after, 4 to 5 months of treatment, many patients who have achieved a response are likely in a confirmed response with multiple scans. And it's possible that after 6 months of treatment, we could safely miss a treatment or two and keep people out of the healthcare system for 6 to 9 weeks while, we're trying to wait for this, the COVID outbreak to hopefully lessen over time. It's important to understand that this is not necessarily evidence-based. This is anecdotal, this is experiential. Patients who are in a response at that point are unlikely to progress if after they've been off of treatment for a few cycles. But again, we don't have hard evidence to support that approach, but we're trying to do the best we can. In patients with localized disease, systemic chemotherapy is actually great because we know it improves survival, improves our cure rates in the neoadjuvant setting. And for us, particularly in New York, it helps us, schedule that surgery much later, right? So some patients who are cisplatin ineligible, that's a different challenge. But for patients who are eligible for cisplatin-containing chemotherapy, we know that's up to 12 weeks of systemic platinum-based chemotherapy, and then an additional 6 to 8 weeks or so of rest before their cystectomy can be safely done. That is a significant amount of time that allows us to hopefully get through this whole thing and allow us to safely schedule cystectomies again. And so to have neoadjuvant cisplatin-based chemotherapy as such a strong component of a standard of care already really strengthens the argument in the era of COVID. The really, really tough part is our patients who are cisplatin ineligible. And for those people, we know that the standard of care is definitive local therapy with either cystectomy as soon as we can schedule it. I still think trimodality bladder preservation is a standard of care. We should be looking at it more closely, especially in this context if we cannot schedule surgeries. But if, let's say, our outpatient radiation facilities are working well, I would counsel patients about that also as an option. And I've certainly done that with a few patients who were unable to schedule a surgery. So these are some of the examples of things that we are doing to treat both patients with metastatic advanced bladder cancer as well as those with localized disease as well.
Great, thank you. So Dr. Mao, what are you seeing?
The one question for Arjun, what about the concerns about immunosuppression with chemotherapy during this time period?
That's a great question, Gary. So I am not concerned about it, and that's not what I've observed in patients who are treated with platinum, is that, in all of our experience over decades, and this obviously not just me, but we don't see a higher risk of viral infections during chemotherapy. Obviously, this is before the era of COVID, which is obviously a very unknown scenario. But we saw the same rates of viral infection in the common population as compared to those who were treated with, let's say, gemcitabine and cisplatin. It's primarily bacterial infections that we're worried about. Now, that being said, though, patients who are, let's say, develop a bacterial infection, they're introduced into the healthcare system, and then they're exposed to COVID. That's another added layer of risk. But the primary risk of chemotherapy, in my opinion, in my experience, is not to increase their risk for COVID infections. In fact, their antiviral immunity is pretty much the same with or without chemotherapy.
Dr. Mao, what's going on up there in Boston as far as when should patients have a delay? Is there some way that radiation can be used to help delay some of the other things that need to happen? What are you seeing?
Yeah, so I see bladder cancer patients primarily in two contexts. One is what Dr. Bladder just sort of outlined, those with localized muscle invasive disease. And in that case, for many patients or for a subset of patients, chemoradiotherapy is a reasonable treatment approach, independent of, other factors. And so I would say that, despite that, I've seen a little bit of uptick in terms of referrals, just for the reasons that Dr. Steinberg outlined with the challenges of getting folks into the OR on time. And so these are patients who are either have received some cisplatin-based chemotherapy and had planned to do either surgery or radiation following that, or those who were ineligible for cisplatin-based chemotherapy and came directly to me. And in those cases, we've been able to get those folks started with curative radiation, programs with relatively little delay. Again, I want to stress that we want to make sure that we treat patients based on the best evidence that we have, with COVID as one of the obviously nowadays large considerations, but you know, many patients may be eligible for radiation independent of COVID, and those I'm obviously continuing to treat. And then also we are seeing some additional referrals for folks who had been planned for surgery, but due to, you know, scheduling and COVID considerations for the OR are now getting treated with curative radiation. And then a much smaller subset of my patients are those patients who are having specific symptoms from bladder cancer. So bleeding or pain due to a bladder cancer lesion somewhere. And in those cases, you know, where patients are symptomatic, we're obviously not delaying treatment. And the advantage, if you will, in that scenario is that we can often use much, much shorter radiation courses to try to address the bleeding. So as few as one treatment or, you know, maybe, you know, a couple of treatments over the course of a single week can often be enough to address specific problems for patients with more advanced disease.
Great. It's really good to know. Thank you so much. Dr. Keeler, I apologize because you dropped off at the last point. So maybe you want to just share a little bit about what's happening in your actual community-based practice and at the local hospital where you're doing your surgeries, things like that, but then also talk about what's your perspective on when is it okay to have a delay, or in the case of surveillance. I know a lot of patients are concerned. They are supposed to come in for their regular cystoscopies, and they're being told it's non-essential, and then they feel like they're being forced to sort of sit and wait and not know if their treatment is working or not working. So what are you seeing in your practice?
Well, what we're seeing, thank you, Stephanie, and thanks for getting me back on. We are
You're breaking up a little
limiting
bit.
the patients we see bladder cancer patients.
Dr. Keeler, you're breaking up a little bit. I'm not able to hear you. Dr. Keeler.
Our office, I think, is a little bit. In the office, I think it's a little.
Dr. Keeler, we're not able to hear you very well. I apologize for the technical difficulties.
Patients can park outside your caregivers can wait outside.
Dr. Keeler, we're not able to hear you. You don't have a very good connection, Dr. Keeler. All right, well, in the interest of time, I apologize, Dr. Keeler. We're not able to hear you very well. You don't have a strong connection. All right, he's going to try to jump back in. We'll see what we're going to go up against. So the three of you are still on. Do you want to talk a little bit about, you know, what each of you have said? Do you have any questions for each other that we can share with our community as far as what you talked about with the urologic perspective, the medical oncology, or the radiation oncology perspective of being, when is it okay to delay treatments or surveillance?
Again, I think that it's important to break things down by stage: non-muscle invasive, localized, and metastatic. And I think that in the non-muscle invasive space, there is going to be some delays from BCG anyway because of our BCG shortage. So actually the BCG shortage has kind of helped us kind of prepare for this time when we're thinking more about who needs maintenance therapy, how much maintenance therapy they should get. Is it okay to miss, you know, a lot of times we have a BCG of 6 plus 3 weeks of BCG at 3 months, 6, and then 12 months. And so a lot of times we're having to skip one of those time periods because of BCG shortage and then give it later. And I think that we're beginning to see that we can be equally as effective by using additional strategies. Sometimes we're giving intravesical chemotherapy instead of BCG. But all of these things, I think that have taught us that we can allow less rigidity in terms of our scheduling. to try to maintain the patients, keep following them up. I think that it's critically important that you do an outstanding TURBT. And so sometimes if you do a better TURBT, you can forestall some of the intravesical therapy, which is adjuvant therapy to prevent a disease from coming back. But as you know, right now in New York, we're not doing any TURBTs and haven't since the latter parts of March, and we're not going to be doing any in the entire month of April. But I think that, again, when we look at the risk table analysis and the data, we do have time. I don't think that a patient with high-risk non-muscle invasive bladder cancer is going to lose that opportunity to still be cured and potentially even continue to preserve their bladder, even though there may be a couple of months of delay.
Well, I certainly appreciate what you had mentioned earlier about the progression rate is relatively low, even with the non-muscle invasive disease within 12 months. So I hope that that gives people a little bit of comfort in knowing that if they can't get in right away, that you will be first on the list to be able to get back in once things are up and running back to normal again. So any other comments? Dr. Bladder, Dr. Mao? Well, I'd like to jump to the next question then, if that's possible. What constitutes an urgent need for care, and what should patients and their families know about what to expect in the doctor's office or in the hospital when they do get in there? What do you see as, what, you're going to have to come in for care. This is a big risk. What should people with bladder cancer be aware of that they know that they need to let you know they need to come in?
Well, I can just say that, the majority of folks that I'm seeing or that I'm meeting virtually, even for the first time, who have a new diagnosis are those with the muscle invasive cases. And in that case, I do think that, getting a plan in place, even if it includes things like virtual visits to substitute for in-person visits up front with urology, medical oncology, and radiation oncology, I do, as much as is possible, think that it's worth continuing to do that in a timely fashion for those folks, again, diagnosed with newly diagnosed muscle invasive disease. Dr. Steinberg touched on the non-muscle invasive space. I think in the muscle invasive space, at least getting a plan in place and meeting, albeit even virtually, with the providers, in as timely a fashion as possible to get the plan in place, understanding that the plan may be not exactly the same as it would be in a non, sort of COVID environment, but in my view, having those discussions again in a timely manner makes sense, and those thankfully can often be done, remotely at many centers.
Dr. Keeler, I see that you're back on, and I'm very glad that you're there. Give me 2 seconds. Dr. Bladder, did you have anything else to add as far as chemo or immune therapy, if people are experiencing any of the adverse effects or side effects from these treatments, when should they come in? When is this really imperative, or should they be calling you and maybe do telehealth to try to find a solution before they get into the hospital? What are you seeing?
Yeah, so I think one of the things that this COVID outbreak has really forced us to do is accelerate our timelines to, moving toward a balance of telemedicine versus in direct patient to patient, or physician to patient visits. And that's been part of the imperative for many medical centers for a while, but they were slowly rolling it out because obviously, not everybody's on board and there's a huge learning curve involved with it. Well, we don't have that luxury anymore. And so it's coming to us front and center. So I'll tell you, within a week, maybe about 7 or 8 days, I quickly saw a little video icon show up on my Epic schedule. And that's basically the icon that tells me that the patient is checked into a virtual waiting room. And I click on that message, and it activates the visit on my phone. And all of a sudden, I'm seeing that patient, live and in person across a secure messaging platform, and it allows us to see patients virtually. And we did this very quickly. We had no choice, right? And so what I think that, what it's helped us do in a very short period of time is help us understand, really, in fact, how many patients do we really need to see face to face? It's really forced us to ask that question. And it turns out that we probably don't need to see that many people face to face and have patients come through traffic and parking and just the amount of burden it does to take them away from their jobs and so forth and their otherwise busy lives to come to their doctor's appointments. And it allows us to interact with them very freely, but via video. So that's been incredible, especially for our patients on surveillance who may have otherwise 5-minute visits, 10-minute visits that don't last that long. They spend more time in transit than they spend actually with us. So that's been great. What it's allowed us to do is actually to spend more time with patients who really need our attention, to be honest. Patients who have a lot of symptoms, et cetera. And so that's been great. That part is actually one of the little silver linings in all of this. And then as it relates to your question, which is how do we manage patients who are developing toxicity at home, having these video visits is really critical and allows us to at least lay eyes on the patient. I've told every one of my patients that one of the best things about them coming to see us is that I get to see you. And a lot happens because I can lay eyes on you. Now, obviously, video is no perfect replacement for this, but it has to be good enough. And so we've stayed in really close communication with our patients. They know exactly what symptoms to report. And if they do, they know to get in contact with myself or my nurse. And we come up with creative ways of treating these patients without actually having to physically. There will be some hiccups along the way. There naturally will be.
So I should turn
So far, it's
the
going quite well.
Well, this is great. I think we're all going to be learning something that is going to get to my last question of the day, where we see this going in the future. But Dr. Keeler, it's so nice to see you and to be able to hear you now. So thank you so much for joining us as our community urologist. And can you just talk a little bit, just kind of recap what we've already covered in the sense, are you changing any protocols in your practice? And when do you think it's okay for patients not to come into your office or, for treatment and or surveillance? And then also, when should they definitely come in to see you? What's important from the community perspective?
Thank you for having me back, Stephanie. Like I was trying to say, we have very few patients come in now, maybe 20%. Like everyone else said, we're evolving with telemedicine, which is great, but obviously not applicable to bladder cancer patients all the time. And we're still giving BCG. The patients who get BCG are high-risk patients because, as you know, Stephanie, we've had that national BCG shortage, so we've had to allot them carefully. So most of the people that are getting BCG are not your TA multifocal, but the carcinoma in situ, the T1 patients, and they're coming in still. Unfortunately, we have patients, a little easier than in New York City. Patients, caregivers can wait outside. We have them literally come from their car through the waiting room to the actual office room. So we have very few people in the office at any one time, in addition to seeing less patients. And I think by and large, it's individual. If somebody had a recent T1 disease and have only gotten 2 doses of BCG and they're healthy patients, we're still seeing them. Somebody's 86 and scheduled for their doses 7 through 9, and maybe they're on steroids or something. Maybe they want to wait a little bit. So it's an individual approach based on the seriousness, and there's, of course, patient anxiety matters too. I think it's a little bit easier for us because we're not in a big university setting to take care of some of those patients. In the hospital, a little different. I mean, Dr. Steinberg's in a worse situation. I did have done some bladder cancer surgery for people that I'm concerned are younger and may have muscle invasive disease, but they're very limited. They have to be symptomatic. We're certainly not taking anybody back with low-grade tumors, so it's a pretty similar approach.
Excellent. Do any of you have any questions for Dr. Keeler about what's happening in the community?
Are patients reluctant to come into the office? Are you having to do a lot of rescheduling, and are they staying home and delaying because of their concerns?
I personally and many of my partners are trying to have patients delay when they can, especially if they're non-cancer diagnosis. And there are some people that do want to come into the office, and there's some people you want to come in and some people you're trying to keep out of the office. And so it's that judgment between you and the patient, I think, probably the same as you too. It's a pickle sometimes.
Yep, absolutely.
So really looking at, you guys are learning on the fly. This is not anything that people have been prepared for. What do you think is going to happen when this all passes, which we hope is very soon? But do you think we're learning better ways to treat bladder cancer patients because of what we've had to do to accommodate the COVID-19 pandemic?
Well, I can echo what Dr. Bladder said in that it's it's been a catalyst for change to telehealth, which I think in many cases we're learning is in many ways as good and or better for patients that don't need to be seen in person. And so I think that's going to be one effect of this that's going to persist, is that we're going to think hard about who needs to come in to actually physically be seen by a doctor. Oftentimes many follow-up patients, it's more of a social visit, thankfully. And so, are those things we could be doing virtually instead? So that's one aspect where I can see, we went quickly from sort of, 0 to 60 miles an hour on the telehealth front. And I feel, I see that sticking around and that actually being a benefit for patients, potentially long after COVID is gone.
One of the things that I worry about, Stephanie, is that we're all worried about from the time of muscle invasive diagnosis to treatment, and that we're adding delays. Patients are getting neoadjuvant chemotherapy, and there may be some delays, and they're getting surgery or radiation, there may be some delays, especially for surgery. But the real delay for bladder cancer patients is not from the time of diagnosis to treatment. It's from the time of symptoms to that initial diagnosis. And all too often, patients have blood in their urine or they have symptoms of their bladder cancer, and they're not coming to see the urologist. And I worry that they get into a habit. Well, I'll just do everything over the phone, or I got some symptoms, and that they're not going to ultimately be seen by the urologist in time, and that there will be significant delays in the initial diagnosis. And that is one of my greatest fears as we evolve to patients not being comfortable coming to see the doctor.
Yeah, I mean,
it's a really good point in April, because remember that May is Bladder Cancer Awareness Month, and Beacon is doing our part to really make sure people are aware of that. But again, getting people to think about going in to see their doctor if they can't just get an appointment, or their doctors are saying we can't see you if this is not essential, then that also makes it a significant challenge. So anybody else have anything to add before we move on to questions?
To Dr. Steinberg's point, it's that is one thing that does weigh on me, is that there may be, over the span of the next actually the preceding 5-6 weeks and the next several months, there may be patients that are at home right now with underlying symptoms of a malignancy that are subtle, they're subclinical, they're minimally symptomatic, and they're being counseled, well, listen, what you're having right now is not life-threatening, and so therefore we can safely delay you getting evaluated and diagnosed. And with that comes the risk that when we finally are able to kind of safely allow patients to re-enter the healthcare system, and social distancing rules get relaxed a little bit, and so when the patients are re-entering the healthcare system again, that we're going to have a lot of advanced malignancies or the malignancies that have been delayed in diagnosis because of it. And the healthcare system is going to feel that. And this is not just bladder cancer, obviously, right? This is across the spectrum of disease. And that is something that I think we all need to be aware of is likely to happen.
Stephanie?
Yes, Dr. Keeler.
Am I on?
Yep.
Too often to echo Dr. Steinberg, you see somebody treated who had gross hematuria for a urinary tract infection with no culture, maybe treated with antibiotics twice, and they're a smoker, and they come in 6 to 8 weeks after the initial hematuria, realizing it was never a urinary tract infection. And we still see that from time to time, and it's during these times it's a little worrisome.
Can you talk a little bit about what's going on now with clinical trials. Clearly, clinical trials that are dealing with COVID-19 are opening up very, very quickly. But the existing clinical trials, what are you seeing with clinical trials right now that have already been going on for bladder cancer? Not specifically for COVID-19, but the trials that are already ongoing. What's the risk? What's the problem? What's happening with that if in key institutions and even some of the clinical trials that are happening in the community if patients can't get in? What do you see going on with that?
Well, you know, Stephanie, clinical trials really have to be a labor of love, and it really does require a tremendous amount of extra work and visits and a lot more patient interaction with the healthcare system. And I think that patients aren't currently on trials. I think we need to do everything we can to continue them on trial. Newly enrolling patients, I think, is problematic right now.
Stephanie?
Sure. Yep.
Problematic also too, because a lot of our cancer trials in general have not inappropriately been shut down. The Keynote 57 is still open, which is the Pembroke trial, but all our other bladder cancer trials in the private practice and prostate for that matter have stopped accruing during the COVID crisis. So, yeah, like Dr. Steinberg said, it's a labor of love, but there is still one trial that I know of open. I'm sure there's others that other doctors know too.
I will add just a few other comments, you know, to Dr. Steinberg and Dr. Keeler's, which I agree with. It's you need a lot of infrastructure and support, you know, and the number of visits. So it's not just, you know, the physician and also the research nurses may be interacting with patients, but it's all of the data coordinators, the specimen, you know, processing folks who collect tissue and blood, and so there's a lot of machinery behind every trial. And if those people are not physically present, you know, it's really tough to conduct this research because it's both for the benefit of the patient as well as benefit of future medicine, because that's why we do these trials. So we learn a lot, and our opportunities to learn will be compromised in this era. But the other larger issue, you know, and this is a mandate that I've kind of put upon, and also in our cancer center, which is really to really only focus on trials, at least right now, where the patient stands to benefit substantially above the standard of care, or it provides a treatment option to a patient for which the routine standard of care is simply not available. So for instance, a bladder preservation trial in BCG unresponsive disease, that may be their best option because we can't schedule a cystectomy. You know, or a bladder preservation trial in muscle invasive disease when we cannot schedule a cystectomy. And so I think that's kind of the larger message here, is that we should really focus on research where the trial really is a substantial benefit above the standard of care. And that's what we've done here.
Yeah, I would say I'll echo that sentiment. In Boston, you know, we've obviously been less affected to date by COVID than New York, but we've taken a pretty pragmatic approach to clinical trial enrollment. You know, really thinking hard about who stands to benefit the most from enrollment on a trial. We continue to enroll bladder cancer patients on trials, you know, but certain aspects. So for one example that, you know, I know is no longer the case here in Boston, at least, is that we aren't routinely collecting biopsies strictly for research purposes. And so, you know, that's a thing that, you know, our patients are very generous, and they agree to undergo these biopsies for research purposes, and that's a huge benefit for our research infrastructure. But right now in this environment, you know, that's one thing that we can really tighten up ship, and so we aren't doing those sorts of things, but we continue to enroll people with an eye towards those who stand to benefit most from enrollment on the trial.
So I'm going to open it up to see about the questions that have been submitted by the participants on this webinar. There was one, I think this question regarding TURBT delay. While invasion is unlikely, what's the risk of its recurrence? I think, you know, Dr. Steinberg, you mentioned the reduced risk of progression is relatively low, at least in the first 12 months. But what about the chance of recurrence if you haven't been able to get in for surveillance? What do you think? It's a little hard to predict that, but what do you want to tell patients?
Yeah. Well, you know, one of the worst things in the world is have to do unnecessary trips to the operating room for additional TURBTs if we can prevent those recurrences with intravesical therapy and so forth. I think that, again, a lot of our protocols are not necessarily evidence-based. A lot of them were kind of empiric guidelines. I think that in general, we probably survey too often, and that one of the things that we may learn from this is that we can survey less often. I know that as I've been doing this, it's now a generation that I've been seeing bladder cancer patients, that I am stretching out my surveillance for even high-risk non-muscle invasive bladder cancer patients. I mean, I think that the first 12 to 24 months, a lot of times, tells us what the natural history of that cancer is going to be, how well it's responded to intravesical therapy. And so that, you know, if I've got a patient who's 15 months out and they've been disease-free for 15 months, they may not necessarily need another cystoscopy in 3 months. We can do it in 4 or 5 or 6 months. So I think that we're going to learn a lot about potentially eliminating unnecessary cystoscopies and procedures. I think that the patients, they dread having all their cystoscopies and instrumentation. So, but I think that by and large, delaying some of the surveillance for a period of time is safe.
Does that also apply for things like CT scans, chest x-rays, things that people will be routinely asked to go in and have these monitoring tests done? Should that also kind of apply to those things?
I think so.
Mm-hmm.
Go ahead, Lewis. Go ahead.
A couple things. One, I think, as Dr. Stein was alluding to, how far out from, how long have you been no evidence disease? I mean, the first BCG, after 6 cycles, the first 6 of BCG with carcinoma in situ or T1, you may really want your cysto and it makes sense. On the other hand, you're 15 months out. And the other thing I wanted to add was markers. You know, you're 15 months out, maybe from something serious, CIS, T1. You look back and the last FISH test was negative, or if you use CX bladder or some other marker or even cytology, all the markers, you can give patients data that you already have to say, hey, your FISH testing was negative, your CX or cytology was negative, you're compromised, let's wait till July, and give them some comfort based on some other data. So I think some of the urinary markers, along with the natural history of the disease, might help comfort patients who have justifiable anxiety about the disease.
Kent, I know that the radiation in combination with chemotherapy and the selective surgery is used in the bladder preservation mode. As far as people coming in for the regular surveillance, when they've chosen that option, do you have any comments about that?
Yeah, the surveillance schedule after bladder sparing trimodality therapy is somewhat similar to what folks do after cystectomy, obviously with the addition that they would need a cystoscopy. So, you know, again, I think it's pretty case dependent. You know, that first couple of scans and cystoscopies after completion of chemoradiotherapy, I think are important to understand, again, that you know what the response to treatment has been and get a sense of what the natural history is likely to be. But you know, again, as patients, you know, to echo the sentiment, as patients get further out from treatment and have been and have not had any evidence of disease recurrence, you know, I'm certainly you know, pushing those patients back, you know, a month or two and not really thinking twice about it, because I think that on balance, you know, avoiding that trip often from far away to come for a day of clinic visit, you know, and scans and labs, you know, probably makes sense to put to delay, you know, for a month or so in many cases without really any effect.
Yeah, I will just add one additional comment to that, is that, you know, so for patients after definitive local therapy for muscle invasive disease, whether it's a cystectomy or chemoradiation, you know, our scans are every 3 to 4 months in general for up to 18 months, and then every 6 months for the next 18 months, and then yearly thereafter, which is kind of the approach I've done both on studies as well as standard of care. And so I don't think that that's that frequent of imaging, or at least number of visits, right? So every 3 months is not the same as every 3 weeks visits for treatment and every 2 weeks on, 1 week off for treatment and so forth. But one way to minimize, number of trips and et cetera, is that if a patient's scans are fine and they obtain their blood work locally, there's really no reason for the doctor's visit, which is to review the results and everything, to not be virtual. That makes perfect sense. But I don't think that we should suddenly not scan our patients at the intended frequency, because remember, those guidelines were developed on the basis of timing of recurrence, the frequency of recurrences and when they occur. And so the risk of, let's say, pushing scans out is that you miss a recurrence that could have been caught earlier. Now you delayed it 2 to 3 months, and you're in a tougher situation than you should have been. And the purpose of scans, let's say every 3 months in patients who've had local definitive therapy, is to capture metastatic disease before it is symptomatic. And so that you have time to think about treatment and start the patients on treatment. So I would argue that we need to stick to our schedule, but perhaps eliminate the number of doctor's visits that aren't necessary, especially in the context of negative imaging. Now, the cystoscopies, I think, are really important early in the course of treatment. You don't know what you have in the bladder until you've looked. I think our 2 urologic oncologists will agree, you don't know until you've looked. And so I think that those are really important in the first 2 years after bladder preservation. Maybe we can space those out after that, but in the first 2 years, it's really critical.
Yeah. Well, this is all really important. I think there's a lot of concern from patients, even those that might have had surgery a year ago or longer, and they have, whether they have a radical cystectomy with a diversion or the TURP and all the treatments, they're just really concerned about should they go into the healthcare providers for these treatments. So you're basically saying there's a little bit of wiggle room. I know obviously this is all being driven by what the state and local health departments are saying people should be able to do. We're obviously all socially distancing, and this concept of medical distancing is really hard for patients, I think, with any kind of cancer, but particularly with bladder cancer, because it has such high recurrence rate. Any advice that you can share with them as we begin to wrap up this program today?
I think I think the patients are pretty cognizant. The ones that come in, by and large, have masks. Some of them are coming in with N95 masks that I don't have. They're pretty on the ball. I was like, hey, can I borrow your N95 mask or have one? So they're pretty astute, especially the ones that show up.
Yeah.
My advice is that this is a very important time in kind of in public health but it is going to be temporary, and eventually we'll have those we'll get back to a new normal, but it will be a new normal. And I think at the end of the day, the delivery of care to patients with bladder cancer or all cancers will be, I think, much more efficient. We will find things that are necessary, and we will eliminate the things that are unnecessary, and ultimately patient care is going to benefit from all of this. But I do think that that's several months away, unfortunately.
But one of the things that we've done throughout the history of our cancer management is that, especially in the pediatric population, we use less chemotherapy than we used to. We use less surgery than we used to. We use less imaging than we used to. And a part of that is because children, by and large, with cancer are involved in clinical trials. And so the real tragedy would be that we lose our infrastructure and our clinical trials in bladder cancer, because, how often you should get a CT after neoadjuvant chemotherapy or after cystectomy, after radiation. Those actually probably are more important questions now than were in the past. And so to tighten up those algorithms and tighten up those surveillance imaging requests by the healthcare providers are a much more important question today moving forward than they may have been 3 months ago.
Dr. Mao, do you have anything to add?
Yeah, no, I agree with what everyone has sort of said. And, as much as, as unusual and as unprecedented as this landscape is, I think that the important part is that we, continue to deliver sort of evidence-based care and be thoughtful about the way we manage patients. Because, what we don't want obviously to happen is for, these temporary changes induced by things like COVID to really impact the quality of care we're delivering on a patient-by-patient basis. And so I think, we're all doing our best in this environment to be thoughtful about the ways we deliver care to maximize both, the cancer outcomes as well as minimizing risk of our patients, in this really unusual times.
Well, I want to thank everybody for joining us, for those who dialed in to join us online, and especially Dr. Steinberg, Dr. Bladder, Dr. Mao, and Dr. Keeler. And I'm so grateful that you got online. Finally, we were able to hear you. So I'd like to thank everybody, and I'm going to go ahead and end this program. I'd love to invite everyone to please visit our bcan.org/COVID-19 FAQs, because we're keeping that updated as we begin to learn more and the research evidence is being published. We're going to keep that updated so people can have a reliable, up-to-date resource to learn more about the impact of COVID-19 on bladder cancer and patients and their communities. I urge everybody to follow the CDC guidelines about social distancing and medical distancing. Wear a mask is a good thing. And thank you all for joining us, and we wish you all good health.
Thank you.
Thank you.
Thank you all so much.
I couldn't get on Zoom.